Hello, everyone. Thank you for joining us today for our featured webinar entitled The Primary Care Physician's Perspective, Could This Be LBD? I am your host, Deidre White, Marketing and Communications Manager with the Lewy Body Dementia Association. This webinar is being recorded and will be posted to our YouTube page for on-demand viewing post-event. Shannon, slide's not advancing. Our faculty presenter for today's webinar is Dr. Charles Driscoll. Dr. Driscoll is an emeritus clinical professor of family medicine at the University of Virginia and a clinical associate professor of family medicine at Virginia Commonwealth University in Richmond. He is board certified in family medicine and geriatrics with special interest in dementia and frailty in the elderly. Together with his wife, Jean, Dr. Driscoll and his wife founded and facilitated an LBD support group in Virginia for 3 years after both served as caregivers for close family members with LBD. After Dr. Driscoll has shared valuable insight on appropriate LBD patient care in the primary care setting, I will follow up with information on how LBDA provides education and support related to LBD. The webinar will then close with questions from the audience. Before I turn the program over to Dr. Driscoll, we would like to thank you for the tremendous response we received to the pre-test survey. Again, we wanted to learn a little bit more about you and get a general sense of your knowledge of LBD prior to your participation in this webinar. We see here that the majority of you are caregivers, either of someone diagnosed with LBD or that you're looking just to get a little bit of information on the disease. There are actual patients who have joined us today as well, and we welcome you. And also, we received a significant response from the healthcare and media professional community. And we thank you for attending as well. Here we learned that many of you first learned about LBD, looks like more than a year ago. And almost all of you indicated that primary care physicians are not knowledgeable about LBD. Based on the response you have shared with us, it's safe to say that we understand that in general, it is challenging to identify and diagnose LBD. Dr. Driscoll will help shed some light on this momentarily. Also, the overwhelming majority of you were able to identify key symptoms associated with LBD by selecting the one that is not generally associated with this condition. And for our last question, nearly all of you believe that it is important to attend doctor's visits with patients with LBD to share information with physicians. Again, we want to thank you for the tremendous response to this pretest. We will be sending you a post-test shortly after the conclusion of this webinar to see if any information shared with you today has improved your knowledge of LBD, positively altered your perspective on the challenges in diagnosing and managing the condition, and perhaps even made you more curious to learn more. But for now, without further ado, I turn the program over to our featured presenter, Dr. Charles Driscoll.
Thank you, Deidre. I think it's a privilege to be asked to share some insight with our audience to try to increase their understanding of dementia with Lewy bodies. I have been a family physician educator most of my life, and I sometimes speak to primary care physicians on the topic of dementia with Lewy bodies. I've gained my understanding of this condition from my geriatric practice, but more intimately as a care provider for 2 family members with the disease. When I went to an audience of about 400 primary caregivers, I asked for a show of hands of those who had taken care of a patient or were currently caring for a patient with dementia with Lewy bodies, and less than a dozen out of 400 raised their hand. After my presentation, I asked the same question. This time, almost everyone in the room recognized that they had or were currently following a patient with dementia due to Lewy bodies. So I would ask the audience to not think any less of these physicians. The recognition of dementia with Lewy body is very challenging, and a primary care physician often has a single or maybe 2 visits to try to identify what the condition is, and it just can't be done in that short a period of time. Also, the office visits are very short with primary care, and they really need to take a little more time to gather the information. So today, I kind of like to discuss the nature of the condition as it presents to primary care physicians and indicate some way that if you're a patient, family member, or caregiver, that you could help the physician recognize this problem and deal with it a little more effectively. As we know, the current statistics from the Alzheimer's Disease Foundation shows that about 5.3 million people are currently affected with Alzheimer's disease, and 1 person is diagnosed every 70 seconds. So this is quite an astounding figure. But many of those patients are also suffering from Lewy body dementia. May I have the next slide, Deidre? These are the objectives that I'm going to cover today. And if you find that you need more information about any one of these, we'll have a question and answer period later in the webinar. Next slide, please. A medical school professor once told me in our diagnostic medicine class, when you hear hoofbeats, think of horses, not zebras. And his point being that common things occur commonly, so you want to look for the common things first. But he also cautioned us that an occasional zebra will run with the herd, and if we're not watchful, something important may slip by. So I intend to give you a short course in zebra identification today, because up until now, dementia with Lewy bodies has been under-recognized and under-managed. Dementia with Lewy bodies is a spectrum disorder, and it shares its pattern of destruction of neurons with multiple system atrophy, Parkinson's disease dementia, Down syndrome dementia, and problems in brain iron storage. So there are a spectrum of these conditions that can appear with the same symptoms. And there are numerous conditions that can produce symptoms of dementia. So, and by dementia, we mean loss of memory, and then a challenge in 2 or more other cognitive changes, such as language or motor skills, problem solving, or visual-spatial skills, and that interferes with daily functioning. So once the diagnosis of dementia is clear, we set about to find out what kind of dementia. And although Alzheimer's disease is the most common among the dementias, there's a very large overlap, and patients can have 2 types or even 3 types of dementia, let's say Alzheimer's, Lewy body dementia, and vascular dementia, all existing together. And I've seen a number of these patients. Since there's no blood test or imaging technique that's currently guiding the diagnosis, physicians are left with only the clinical history to make that call. Onset and progression is variable. The naming is confusing. If a case is never presented in the way it is observed, it's easy to miss the diagnosis. Next slide, please. This slide may help us take a look at the two main types of dementia. And when I say two main, of course, Alzheimer's disease is the leading cause of dementia, but Lewy body is right behind at number 2. And while they share a number of things together, if you're on the front lines in the heat of battle with a patient who's exhibiting bizarre behavior change, there's an immediate solution needed. There's a family that's trying to get answers and get to the bottom of the issue, and an awareness that no cure is present. It's really hard for the physician to pick up on some of these clues. And it's sometimes more expedient to just make the diagnosis of dementia. But there are some things that we can do for Lewy body, and there's a different course and a different prognosis that makes it important to try to tease apart these symptoms. So if we look at these two major causes, they can both present with memory loss, but Lewy body has other things that present, perhaps dramatic changes such as hallucinations, delusions, paranoia. And in Lewy body, we're more likely to see a motor dysfunction that presents early in the course of the disease. And by motor dysfunction, I mean Parkinson-like symptoms or tremor or unsteadiness of gait, multiple falls. And those things don't happen early in Alzheimer's. They happen later in the course of the disease, although they can occur in both cases. Again, hallucinations and delusions are rare in Alzheimer's, but very common in Lewy body dementia. And Alzheimer's tends to have a very slow, steady decline, whereas there can be dramatic changes with Lewy body. It's sort of an on-off phenomenon, and one day they can look perfectly normal, the next day be witnessed to have problems. So it's important that these minor differences be called to the attention of the physician, and a more accurate diagnosis can be made. Next slide. Well, we want to attain an accurate diagnosis. And really the gold standard, the only way to really be sure, is to do a brain biopsy. But that really isn't necessary, and most patients wouldn't agree to it anyway. So how do we work harder at getting a better identification? Well, there are some red flags that we need to recognize. First of all, these patients, they respond differently to medications. And neuroleptic medications, which are major tranquilizers, sleeping pills, things of that nature, they can have a very paradoxical response or an extremely heightened response, which borders on toxicity, even from the usual dose of medication. So if you see a patient react adversely to one of these drugs, be sure and report that to the physician. Also, our patients with Lewy body dementia, they may have a better response from acetylcholinesterase inhibitors, such as Aricept, rivastigmine. They may be the most effective long-term control for behavior disorders, but in the case of Alzheimer's disease, not so much. The Parkinson's disease medications that may be started because maybe the motor symptoms appear first, they can actually interfere and make the behavior issues worse. So sometimes one has to make a choice between symptoms. Do you want to improve the hallucinations and delusions, or do you want the motor function? So choices are required. As I mentioned previously, Alzheimer's prognosis is different. It's slower, and it takes maybe 8 to 10 years, with some people living up to 20 years after the first signs emerge. Whereas dementia with Lewy body has a prognosis of 2 to 7 years. Time is shorter, and sooner advanced planning is required, and more family support will be needed. The other importance of an early diagnosis is that as you read the literature, almost weekly there's new information. So I think that the sooner we can reach a diagnosis and know exactly what condition we're treating, the more prepared we'll be to start new therapies that come along. All right, let's look at the next slide. This is going to be, I think, an important issue for just about everybody, and that is who takes the first look at dementia with Lewy bodies. And many times this will not be in the doctor's office, it'll be in the emergency room, because an acute behavioral symptom triggers a visit to the emergency room maybe in the middle of the night. And the continuity of information is important. If we don't get that information from the emergency room, we as primary care physicians are not going to see the whole pattern of the illness. The other problem that we run into quite frequently is this good one day and poor the next. And the patient's unsure of what's happening, the family is unsure of what's happening, and maybe there's something going on Monday that looks abnormal, and by Friday, when they get into the physician's office, normal seems to have returned. So the physician never gets a true look at what's happening at home. And there are conditions that will mask the diagnosis of dementia. For example, if someone has a previous history of mental illness, such as schizophrenia, depression, any of the psychoses, this may mask whether it's really a dementia or just a manifestation of another mental illness. That makes the diagnosis hard. And then, of course, physical problems, thyroid disease, problems with endocrine imbalance, stroke, these things can also mask and look very much like a dementia. And finally, I think we have to recognize that dementia is somewhat of a stigma. It's been more so in the past, but there's still families that I've encountered that are reluctant to tell the whole story that they've witnessed or suspected because it's embarrassing for them to report on how things have appeared. Next slide. So what we have to do as primary care physicians, and you as care providers and family members, we have to work together as a team, and we have to put this whole thing together. So if we're going to identify Lewy body dementia, we need to know about all of these things. We'll start at the top with visual hallucinations and work clockwise. So hallucinations, delusions, these are red flag conditions for Lewy body, and particularly early on in the course of an illness. They're very common, they're scary for families, but they can be controlled. The motor dysfunctions that occur are also early in the course of the illness, and handwriting may change, ability to handle a fork at mealtime may change, ability to shave. So these motor dysfunctions need to be looked for and reported. The patients themselves often won't know exactly what's happening. Autonomic dysfunction refers to problems like urinary incontinence, problems with aspiration, and all of those things need to be identified. There is a red flag disorder that's called REM sleep behavior disorder, and that's where someone acts out their dreams. And they have a sleep disturbance and they act out their dream, and it can be very alarming and very even violent in the middle of the night. So that has to be something that is reported. Fluctuating levels of attention. I have seen patients who will be awake, talkative, and conversant. They will take a nap, quote unquote, and be asleep for 2 days. So these fluctuating levels of attention, they mimic delirium. You have to make sure it's not a delirium or a case of acute physical change. And then the cognitive dysfunction, the memory loss, that looks like any other dementia, so it all needs to be put together. Next slide, please. One thing I would encourage is to keep a symptom diary. When you see these things happening, write the date, time of day, and what the symptom observed, and take it in and share with your physician. Now, it seems easy, now that we've kind of gone through these symptoms, and one would wonder, well, how can a doctor be in error of their diagnosis? Sometimes I've even seen family members who have come to me as a geriatrician consultant, and they'll express anger at the first physician, whoever that was, who saw the patient and didn't correctly identify what was happening. This mistake is an honest one, I can tell you, and it's a mistake I've made. But because the family is starting the grieving process at the loss of their family member, because death is not the only loss. If mom isn't mom anymore, she may be lost to the family. And then they become angry and they become slow to forgive. And I think getting to forgiveness and past the anger is a real struggle, but it's worth the effort. And more attention can be focused on making every day count for the rest of the patient's course of disease. Now, the disorder was discovered in 1912 by Dr. Louis, but it really wasn't defined until 1996. So we have an 84-year gap here where nothing happened with recognition of this disorder. And it didn't become an officially recognized disease until 2005. So that makes the current body of knowledge very new. And myself included, those doctors who graduated 20 years or more, they weren't taught about this disease. So it has to come to them in a different format, in continuing education. Physicians are busy, and if they're rushed and they have a waiting room full of patients, they're going to opt for the best diagnosis they can make, which is usually Alzheimer's disease, if they want to play the odds. Some doctors, geriatricians and neurologists, for example, have had to get up to speed quicker than others so that they could deal with this, because it is really a significant part of their patient load. Another aspect of this difficulty is that the breadth of primary care requires a primary care physician to keep up in many different areas. And the composition of their practice may be completely different. They may take care of a lot of children, or they may take care of a lot of middle-aged folks, but not have a lot of elderly. So if you don't see this condition frequently, you aren't going to recognize it. I personally can admit that I didn't recognize a case of dementia with Lewy bodies until 20 years after I started practice in 1971. So it takes a while to learn these things. Let's look at the next slide, which will show you how you can help your doctor. Because really the key issue here is let's get to the diagnosis as quickly as possible. Let's work as a team. Let's work together. We have a common interest. That's the family member. And so we need to solve this mystery and get treatment started as soon as possible. So let's look at the list here. Convey all the information you have observed. Don't hold anything back. Maybe it might not seem important. Maybe there was a couple of instances of incontinence that you'd rather not report on, but I think that is a helpful clue to the physician. So keep a journal. Note all the changes. Take the journal with you when you go to the physician's appointment. That will speed things up if the doctor can look at it and read it rather than have to take the time to elicit each and every item. If you have any contact at all with another physician, please be sure and keep your primary care physician informed. Physicians need to share information, and that doesn't happen automatically. Some cases require a lot of phone calls, also permission forms, and it would be a good idea when you do make an appointment, let's say with a neurologist or geriatrician or other specialists, that you sign a release of information to your personal physician. And that way the doctor will be kept up to speed on what everybody else is seeing. Keep an up-to-date list of all medications. That means over-the-counter, vitamins, etc., and prescription medications, and make sure that that list is kept up to date and every physician or care provider who sees that patient knows about the medicines. For family members, I urge you to go to the office visit with the patient. I have had a patient who I did not recognize the condition because she did not volunteer any information, and it wasn't evident in the patient encounter exactly what the problem was. But once her daughter came with her to the office and told me some of the things that had been happening, it was a snap. So I think it's very important, go with the patient, be upfront, be honest, and let things come out. If you have questions that arise between visits, write them down. That list of questions will help us immensely. And do your internet homework. If you're as intelligent about this condition as the doctor, then the two of you together will make a powerful team. And I would say that most doctors do not mind if you bring up something that you found on the internet and say, does this have any relevance or does it pertain in any way to my family member? And then when all else is not going well and you think the diagnosis hasn't been established, I would gently suggest getting a second opinion or further testing if the disease is still somewhat in an ambiguous stage. And finally, I'd say when feelings and emotions get in the way, take a step back and try a new approach. I can assure you that the physician is just as frustrated as you are when unexpected problems arise and need to be urgently dealt with. So try to be proactive and try to get the emotions under control. With the next slide, I want to tell you about some significant conditions that require you to alert the physician, and I mean like the next day, if possible. And these would be significant acute behavior changes. Doctor needs to know about this. A significant physical change, perhaps the loss of function of an arm or the failure to produce legible handwriting. Loss of independence and function. Usually we look at the activities of daily living like toileting and eating and dressing and grooming, and the independent activities of daily living, which are managing money, using the telephone, finding directions, and problem solving. Look at all of these areas, and if you see something occurring in one of these areas, report it. If you've had an emergency visit somewhere or an unexpected reaction to medication, report that as soon as possible. Falls, accidents, and driving issues. These are things that occur due to lack of cognition and lack of motor function, so they need to be brought to awareness. If there are non-adherence issues, for example, medication is not being taken as directed, that should be brought up, and hallucinations and delusions, they will appear. The course of this disease is absolutely unpredictable. I can tell you that there are hardly two patients who follow the same course. And so advanced preparation, knowing what some of these issues are, and being prepared to solve problems on the fly is what you should do with your physician. I'll take a minute here to talk about treating the behavior disturbances. I think it's important. If we can have our next slide. There's an approach here to understanding and managing acute behavioral disturbances, and an acute behavioral disturbance is a break that triggers an emergency room visit or emergency visit to the doctor's office. And these are conditions that are very, very difficult to manage, and they're also very troublesome for the family. So I think the first thing we want is to manage these appropriately. Step one is always evaluate a physical problem. Make sure that there's not a constipation with no passage of stool. Make sure that there's not a urinary problem that's developed. Check for temperature, fever. Check the pulse, see that it's regular. These are things that can indicate a delirium, and a delirium can trigger a behavior disorder. So first of all, we need to make sure it's not a physical illness. Second, we either have to avoid or reduce medications because it's usually a medication that will trigger something like this. And benzodiazepines, which Librium and Valium are in that class, bladder control medications, these are the most common offenders. And so reduce or eliminate those. They're not essential. And call your doctor and find out what to do next. Avoid the traditional antipsychotics, and those are things that are like Thorazine and Haldol, for example. These things are extremely dangerous in the patient with Lewy body dementia. There can be a malignant syndrome that can occur with the use of Haldol. So we sometimes just give them a card that says they're allergic to it. If we need to use medications for behavior control, we avoid those things and try one of the medications such as Aricept or rivastigmine for a long-term fix. And if it's an urgent hospital prevention kind of thing, we'll use quetiapine or clozapine. There are black box warnings about heart, and the family needs to know that. And then last, use things for their shortest duration. Education, I think, is the key. Next, please. As we're getting ready to close here, I would mention that some of these conditions are not easy to solve. These behavioral symptoms will not disappear with maybe the first intervention. So what do? Well, we hit the books. We start reading about how these conditions have been controlled. And there are non-pharmaceutical methods to do that. If you're doing one thing, do another thing. You just have to experiment at the time. Phone a friend. I think that it's important that people who are family members and caregivers get involved in a support group for Lewy body dementia. It's a sharing of knowledge, and something that worked for one patient may work for you. So phone a friend, get into that support group, and get a consultant for co-management. A geriatrician, a neurologist, or geropsychiatrist, they've all had more experience with this condition and can be of help. And then the final slide, I would just remind you that every ship needs a captain. And that captain, the best captain, is your primary care physician. So don't give up that relationship with a person who's been caring and compassionate and knows your family member well. Even if their knowledge base seems to be lagging a little, you can help them. The doctor, who's the primary care provider, knows the patient is a person. They're not just a disease. They can maintain a central information registry and share with other physicians and can be of help in facilitating referrals. And then when multiple providers exist, there's oftentimes some fighting and back and forth between the physicians, and I'll start this medicine, and I'll discontinue this medicine. And the primary care doctor can arbitrate that dispute and help out with patient advocacy. I think a discussion of advanced directives is important. I tell that even to my 20-year-old patients because you never know when this might be your last day on earth. So a discussion of advanced directives is important for everybody. And finally, I think the primary care physician is probably the first contact go-to person and can provide a lot of support for the family. With this, I'm going to close my portion of the webinar, and I'm going to hand it back to Deidre.
Thank you so much, Dr. Driscoll, for sharing your perspectives on the difficulties, the challenges of diagnosing and treating Lewy body dementia in the primary care setting. To complement what he shared with us today, we also want to take this opportunity to share a little bit more about the Lewy Body Dementia Association. You know, as noted at the start of the webinar, the majority of you are pretty familiar with the organization, but you know, this may serve as refresher, reminder information of the host of resources that we do have available to help you out along the journey, and to also introduce those who are new to the organization to what we have to offer in terms of support for patients, caregivers, and healthcare providers. The Lewy Body Dementia Association, as again most of you know, is a nonprofit association dedicated to raising awareness of Lewy body dementia, supporting people with LBD, their families and caregivers, and promoting scientific advances in diagnosis of LBD. Through outreach, education, and research, LBDA supports all of those affected by Lewy body dementia. So some of you participating in today's webinar were introduced to the organization through our Louis Who campaign. This campaign was launched in April of this year and runs for 1 year. It is a major national advertising, public relations, and social media effort to raise awareness of Lewy body dementia in the general public and healthcare domains primarily. Key information about this disease and LBDA is being shared in the press and social media as well as through the AARP website at www.aarp.org. Extensive educational resources, ways to become active in LBDA, and how to provide financial support can be found on the Louis Who campaign webpage at www.lbda.org/LouisWho. Please share this site with those you encounter who need more information about LBD and support from our organization. So what are some key resources and LBDA has to offer in terms of programs and services? Well, LBDA offers the caregiver link to remind you that you're not alone. Experienced LBD caregiver volunteers are available to listen compassionately and confidentially during life's challenging times. You can contact one of these compassionate volunteers through our toll-free line and also through email. Additionally, LBDA has established 72 support groups across the country. These groups provide those affected by LBD with the opportunity to connect with and encourage others as they deal with the challenges that come with this disease. Find a local support group near you or to join one online by visiting our website. Another resource is our LBDA forums. We know that it can be difficult for caregivers to attend support groups in person. So that's why we created the LBDA forums, where you can meet and share your experiences and insights with caregivers and people affected by LBD. To join, you can email our form at lbda.org, and we want to make sure that you're aware that we're over 3,000 strong. And then finally, our awareness movement. Well, each year LBDA launches a national grassroots effort to help increase awareness of Lewy body dementia. This year's initiative is launching in October, and we will begin announcing different opportunities, ways that you can participate. These opportunities will be featured in our newsletter, and email blast announcements will also start arriving in your inbox very soon, outlining program objectives and ways you will be able to participate in this year's movement. You can also email me, Deidre White, at dwight@lbda.org for more information in the interim. It's safe to say the majority of you are familiar with our website, lbda.org. We have positioned the site as the source of credible information regarding LBD. So far this year, our site has experienced monthly visitors in the hundreds of thousands. One of our key electronic resources is the Lewy Body Digest e-newsletter. This newsletter typically shares information on the latest scientific advances related to LBD, offers good tips on caregiving, and provides a snapshot of what LBDA staff and volunteers are doing to impact awareness across the country. As a constituent affected by LBD, you will have an opportunity to share your story. You can email me for more information. Additionally, LBDA is establishing a strong social media presence. Facebook and Twitter are our primary mediums, but we also have presence on LinkedIn and Pinterest in particular. And don't forget about our YouTube page, where we frequently post interactive content such as our public service announcements. Our Whoopi Goldberg public service announcement is one of our most popular uploads on the page, and archives of our webinars as well. And yes, this webinar will be posted soon after the conclusion of today's event. Some of our featured publications. LBDA offers a range of information and resources, including a downloadable diagnostic checklist of LBD symptoms for individuals with LBD and caregivers to facilitate their discussions with their doctor. Available to download from our website, this tool has been very popular among patient and caregivers and healthcare providers as well. One of our more recent publications, the Medications Glossary, was developed for LBD families and provides helpful information about medications used to treat cognitive, motor, mood, and behavioral disorders. This publication may be useful in discussing the risk and benefits of certain medications with healthcare providers. This publication is also available for download through our website. Soon off the press will be a new resource entitled the Louis Hu Brochure. This publication has been developed to help clear up the confusion as to what LBD really is, especially in relation to Parkinson's and Alzheimer's disease. Watch for an announcement soon regarding its availability. And now we will open up our question and answer session. If you have questions for Dr. Driscoll or myself, please utilize the chat feature to type in your questions. You may do so now. Okay, our first question, as I see a lot of questions are beginning to come in, is from Catherine. For Dr. Driscoll, you say that prognosis is 2 to 7 years. What is the general cause of death?
The general cause of death, it is a continual destruction of neurons in the brain, and it affects all of the areas. Probably the most common cause of death I've seen has been pneumonia, because aspiration or problems with feeding and eating have become too difficult. Pneumonia, infection, those things can be overwhelming in a patient such as this.
Okay, thank you, Dr. Driscoll. Next question is, what is the best way a primary care physician, what is the best way when primary care physician will not coordinate with other doctors? Do you have any suggestions regarding coordination of care?
The patient always comes first, and to get what the patient needs is important. And if there's a relationship that is obstructive to the care of the patient, then I think you have to look for another relationship. And so I would say getting a second opinion, if that is not with the blessing of the primary care physician, there are many ways to do that, including just a direct contact with a neurologist or a psychiatrist or geriatrician in the neighboring community.
Okay. Next question. A family member was diagnosed with LBD by an ER physician and then later with Parkinson's disease by a neurologist. What symptoms would separate these diagnoses?
Well, interestingly, they both have the same diagnostic code, which means that they overlap so much that it's not uncommon to see them exist together. There's just a general way of identification. If the mental symptoms occur first and precede the motor symptoms, then we generally diagnose dementia with Lewy bodies, or DLB. If the movement disorder precedes the mental symptoms, maybe as much as a year, they can have the movement disorder like Parkinson's disease, then we diagnose Parkinson's disease, and if the dementia follows, then it's PDD, or Parkinson's disease dementia. This is just a matter of taxonomy or naming. If you look at Parkinson's disease patients, about 15% per year will develop a dementia. So dementia is certainly a key symptom of Parkinson's disease and not an unexpected occurrence. Sometimes hard to tease these things out, but you have to treat the predominant disease or the predominant symptoms.
Okay, next question. My husband was diagnosed with LBD in 2007. He takes Exelon, Namenda, and Lexapro and has been on these medications for many years. Should I expect to continue these medications for as long as he lives? If not, at what point might it be appropriate to stop them?
That's a very good question, and it's one that many family members have. And I think a corollary to that question is, if I do stop them, is there going to be harm? These medications only control symptoms but do not control the disease. So we have nothing that we can offer to stop the ongoing progression of destruction of brain cells. That's going to occur with or without the medications. So that being said, there's no harm in stopping them. Yes, behavior symptoms can get out of control, but generally speaking, you'll get the control back again if you restart the medicines. I would say that if you see symptom progression despite using these medications, so it doesn't seem that it's helping all that much, or if they've been on for a while and they've reached a condition where these medications aren't really controlling symptoms, but they're just being given, they can be stopped. And there's a time for stopping these medicines. Generally speaking, they have very, very small effects, particularly small effects on cognition. So memory and memory loss are not helped a whole lot. In the case of Lewy body dementia, the best thing that I would go by is the behavioral symptoms. So if the behavioral symptoms are controlled, and they have been controlled ever since being put on the medication, then I would continue them. There were several medications there. They were, Namenda, for example, Namantadine, has never really been shown to be of any effect in the dementia with Lewy bodies. And it's an expensive medication, doesn't have a generic yet. And I think that that's maybe the first one I'd look at getting rid of if you are working in cooperation with your physician. Okay?
Okay. Next question. Is extreme weight loss common in LBD?
Weight loss is common. Patients forget to eat. Nutrition is probably one of the first things that gets neglected. But extreme weight loss may not be. It may be a sign of something else. So if the patient is identified as being a poor feeder, low calorie intake, and you can always, judge the number of calories that go in. If the body weight is normal body weight, probably 1,500 calories a day, it would keep the patient from having any extreme weight loss. If there is extreme weight loss and they have an adequate calorie intake, I would look for another condition. Just because Lewy body is present, it doesn't mean that we can't get thyroid disease or cancer or any of these other conditions that are comorbidities with the primary dementia. So when you say extreme, I'd say if you've got an adequate caloric load and the patient's feeding well, that needs to be investigated further.
Wow, there's like a lot of questions, Dr. Driscoll. I'm just trying to. Here's one about a sleep study. Let's see, where was that? Okay, here's one. Can you address the severe volume loss in the frontal lobes with LBD versus Parkinson's? My husband was diagnosed with LBD due to the brain MRI. Does Parkinson's have volume loss too?
Parkinson's in and of itself does not have volume loss. It's more likely to be identified by changes in the substantia nigra, the posterior, inferior sections of the brain. However, it is a Lewy body condition, and so as Lewy body condition spreads from cell to cell, it can involve the front part of the brain. And that may be why we see more often Parkinson's with the Parkinson's disease dementia following later in the course of the illness. The destruction of nerve cells is what causes the volume loss. And that's why there's probably a better chance of diagnosing the Lewy body dementia, because of the severity of the loss in the frontal part of the brain. It's more associated with dementia from Lewy bodies.
Okay, kind of a question along that same vein. One of the participants wants to know, can a patient be diagnosed with Parkinson's disease first, then years later LBD develops?
Yes, they can, and that is a common thing that happens. In a population study, we have seen that Parkinson's disease can be stable for 5, 6, 7 years, then later the appearance of the dementia. And as I mentioned, approximately 15% of patients with Parkinson's disease will get the dementia each year. So if you're talking about 100 patients with Parkinson's disease, probably 15 will get it. And then the next year, 15% of that 85 may get it. So it does cumulatively show up. I think the data suggests that about 85% of all Parkinson's disease patients will develop the dementia before their death.
Okay, thank you, Dr. Driscoll. We'll take one last question, and then for the remaining questions, we will share those questions with Dr. Driscoll, and then we will try to provide you with the answers electronically. So for our final question, Dr. Driscoll, a participant wants to know, if you think a sleep study is necessary or beneficial for LBD patients who sleep a lot. Does it make a difference in treatment planning or the progression of disease?
No, I don't think a sleep study is necessary. The sleep study may or may not be abnormal. They may appear to be in a normal sleep for 24 hours. So it's one of those on-off conditions. It will show up in some patients, and others you may not see it. The sleep study that might be helpful is early on, maybe even as far as 10 years before the manifestation. Sometimes this REM sleep behavior disorder is difficult to characterize, and that might be, but for a patient who's been diagnosed, it won't be helpful. If you've got the diagnosis of Lewy body dementia, that's just part of the problem, and to be quite honest, spending more money on a sleep study will not be helpful.
Okay, thank you, Dr. Driscoll, for the insight that you've provided today on the challenges of diagnosing and managing LBD in the primary care setting. And I would like to thank all of you for joining us for today's webinar. This concludes today's event. Please watch your email for follow-up information regarding the post-test survey and information on the web archive of this event that will be posted to our YouTube page. Thank you so much for participating, and enjoy the remainder of your day.